The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are here for the next episode of TMD Demystified, and I'm Tony Urbanic. Today we are going to be talking about one of the three causes of TMD. There are really only three causes of the problem, but this title of this episode is going to be Bruxism is not the only cause of TMD. And I phrase it that way because generally speaking, most patients and most dentists believe or are led to believe that really bruxism is the prime mover of TMD. And we'll talk about each participant, both patients and doctors, in a little bit. But again, my purpose in doing these episodes is to teach, but even sometimes more importantly, clear up misconceptions. And that's why the title of the podcast is called TMD Demystified, because there is a lot of bad information out there about the problem, and this is one of them for sure. And it needs a little more explanation. It needs a little more data to make it real to you, that you can go, oh yeah, it's like there's more to this than just clenching and grinding your teeth. So let's go over the basics. I always have to assume that some viewers of this podcast are first-time folks, and that not necessarily people that follow these along regularly. So, and I have to assume that you are a dentist, although I am aware that there are patients who follow this podcast along. I have one patient who actually drove all the way from Dallas, Texas to Nashville, Tennessee to see me, who claimed that she viewed each and every one of the episodes of TMD Demystified, which was quite amazing. So there are three causes that cause the chronic inflammation within the temporomandibular joint, and of course the chronic inflammation which drives all the symptoms. So the three causes that create chronic inflammation within the temporomandibular joint by far is the most common, maybe not least understood, but the most common cause is bruxism. And then the other two are functional malocclusion and acute trauma leading to chronic inflammation. But today we're going to talk about functional malocclusions, define what that is, to talk about how you determine there is a functional malocclusion, and more importantly, how this is related clinically to each patient, and then how unloading a device that unloads the temporomandibular joint handles the problem. And then I guess also critical information is what happens when you have a functional malocclusion. Do you just leave it alone? Do you just let it fly? Do you recognize it? What do you do about it? This is actually a major issue in dentistry, and this stuff is not taught in dental school by far. And so the majority of dentists, whether you be older, middle-aged, or right out of school, the majority of dentists do not spend a whole lot of time doing continuing education. Generally, they do the minimal, usually that the board requires, your state board requires. There are a few that spend a significant additional amount of time in continuing education, but they're few and far between. And therefore, there are very few dentists who focus on temporomandibular joint issues, for sure. I mean, they spend their time, if you're going to do excess continuing education, you're going to do it in areas that you feel more comfortable with. And of course, most dentists do not feel comfortable with dealing with TMD problems or patients at all. So, I mean, that's the nature of it. That's the current situation with dentistry and TMD, United States of America, 2024. All right, so let's just get into the nuts and bolts of this. So there are three causes, functional malocclusion being one of them. So what is a functional malocclusion? Well, like the definition of, it's a malocclusion that creates functional problems. Functional problems being problems with speech, with chewing, with swallowing, and causing pain and discomfort. Those would be categorized as functional malocclusions. Now, again, in the mind of you have to understand what I'm trying to do here. I'm trying to educate you in getting into the mind of the patient and mind of your fellow colleagues about this problem. For the most part, if you have the word malocclusion, then the patient originally, thinks orthodontist. I have a malocclusion of some kind, orthodontist, and orthodontists know how to fix this. Well, that isn't necessarily true in the United States of America 2024, I have found out. And I am sure that there are good numbers of orthodontists who have studied extra and have significant amount of experience with functional malocclusions, who take that seriously and understand that a functional malocclusion may be well beyond just straightening teeth in one way or another, but has to address facial growth, jaw growth, and applying standards and technology as it applies to facial growth. And that is where and why I have a lot to say about this, because I spent my entire career, beginning in my work with the NIH back in the mid-70s as a fellow with the National Institute of Health, National Institute of Dentistry, Craniofacial, that I did a 2-year fellowship in facial growth and development as it applies to what I did then for my rest of my career, which was a lot of orthognathic surgery, and of course, a lot of temporomandibular joint surgery. And understanding facial growth and development has a lot to do with, and is a great advantage for, understanding functional malocclusions, because not all functional malocclusions are caused by crooked teeth. They are caused by problems with facial growth and development of the jaw. So just a brief, very oversimplified comments about facial growth and development. First of all, the major area that creates a proper face in dimensions, both vertical and horizontal, is directed from the temporomandibular joint. The major growth center of the face is the temporomandibular joint. Now, there are other growth areas that are important, but the major one is the temporomandibular joint. And again, without going into detail, my 2-year fellowship and my grant from the NIH had everything to do about facial growth and development. And actually, I proved that you could create animal models with defects in facial growth and development by zapping the temporomandibular joint with a laser, coincident with intrauterine fetal surgery. Intrauterine fetal surgery and zap the temporomandibular joint, basically damaging the temporomandibular joint. And the animal model that I used was rabbits. So I'm just saying that to emphasize the fact that I have a lot of information on this. I have a lot of study in this area. Frankly, if you study it carefully and you read the right books and papers, it's really not hard to understand, because first of all, have to understand how bone grows, how bone itself grows, and then how bone associated with the facial structures grow, and then where the primary growth centers go and what stimulates growth of the face. And that is why everybody has a different looking face. And some faces are very aesthetic and some faces are not aesthetic. But when the bone grows outside the normal parameters, you not only can get into aesthetics problems, but you can get into functional malocclusions. So just to make that point, so that's really what I'm talking about, and that is functional malocclusions can come in all varieties. You can have minor functional malocclusions, and you can have major functional malocclusions. Now, let's go back to where I spent a lot of my time in my career fixing major functional malocclusions, which were, whether they be children that had cleft palates, or kids that had excess or minimal growth of the temporomandibular joint causing hyperplasia, or vertical problems, horizontal problems, growth problems, class 2s, where the mandible did not grow forward anywhere near significantly, class 3s, where the mandible is all out. Treating these kids sometimes, sometimes as early as 6 or 7. Cleft palates were usually treated as early as age 3, sometimes. And then extending this into adults, and the recognition of these problems. As we became more sophisticated, because I came through my training right at the cusp of really some major work in facial growth and development, and surgical correction of facial growth and development, whether it be syndromes or just unusual facial growth and development for both kids and adults, and then disseminating this information to the other areas of dentistry and trying to teach. But it was all generated out of the oral and maxillofacial surgeons' work in the early to mid 70s. I was able to participate in this heavily. And then I came out in a private practice and practiced that technology for, actually I counted the numbers until I quit doing this kind of surgery for 48 years. So the major areas of functional malocclusion are really problems with facial growth and development. Now, when some orthodontists, when they take a look at this, they're only thinking teeth, and that has been for 50 years, to some extent or another, a problem, because they only thinking, well, where the teeth line up, and they forget that the forces that they put on the teeth, one way or another, especially tractive forces on the mandible, can mess with, literally screw up the growth and development of the temporomandibular joint, or retrusive forces also, either way, and also vertical dimension. Basically, to give you the simplicity of it, the mandible is the primary mover. If the mandible grows too much, it is likely, not necessarily, but likely to draw the maxilla with it. That is how normal growth and development goes. The mandible grows and the maxilla comes along with it, actually drawn forward. The midface, the maxilla in the midface portion is drawn forward as the mandible grows. But if the maxilla gets out from underneath the mandible growth, then the mandible is often growing extensively, and the maxilla is left behind. And that's why you can see significant class 3 occlusions. How you crank orthognathic surgery into this is a combination and an agreement between what the surgeon can do and what the orthodontist can do. And that is why the younger doctors now are well aware of the value of orthognathic surgery and how the orthognathic surgeon works with the orthodontist and usually has one or two or maybe more orthodontists in his community that he works with heavily. And those are the orthodontists who understand a little more about facial growth and development. Now, but functional malocclusions do not necessarily have to be big deviations. And as I did orthognathic surgery, my attention was primarily on large deviations, which can cause damage to the temporomandibular joint, thus causing symptoms of temporomandibular joint disease due to chronic inflammation within the joint. But what I learned and gained a lot of experience over time, especially in the past 14 years, as I delved into the non-surgical treatment of TMD, that relatively small changes in centric occlusion, centric relation can have a significant damaging effect on the temporomandibular joint. Now, again, as a teaching experiment, let me emphasize that everyone has two bites. I hope that everyone listening to this understands that. Everyone on the planet has two bites: the centric occlusion and centric relation. Centric occlusion is where teeth have their best interdigitation with natural growth or with the help of an orthodontist or two somewhere in the life pattern. Centric occlusion, best interdigitation. Centric relation, where the mandible goes back to the best and most comfortable position of the condyle in the fossa, which is called centric relation. But as that mandible drops back, it's going to come out of centric occlusion and your teeth will not occlude as they used to. Now, small deviations, fortunately, small deviations, patients accommodate for that problem or issues. Maybe not even call it a problem when it's like, if you have a small CO-CR discrepancy, and everyone is different. I mean, some people can accommodate large deviations and some people can't accommodate a, tenth of a millimeter. But small deviations can usually be accommodated by the patient, fortunately. And so, but some patients, they have a larger difference between CO and CR, cannot tolerate it well, at which point it overloads the temporomandibular joint, which creates chronic inflammation, damage to the joint first, then chronic inflammation within the joint, and then the chronic inflammation drives the symptoms. That is the mechanism. That is the domino effect. So the point being that chronic inflammation can be created by small differences between CO and CR. Now, and all this came to light by using a device that did nothing more, nothing less than allowed the mandible to drop back to centric relation. That is how this thing works. Unloading, actually separating the posterior teeth and having no direction on the anterior platform. In other words, there's no stops, there's no forces, there's no angulation to the anterior occlusion. You're just separating the posterior teeth, which naturally allows the mandible to drop back posteriorly into its most comfortable position within the glenoid fossa, condyle in the glenoid fossa in its most comfortable position. That is why forcing the mandible back, I've seen so many dentists, well-meaning, well-experienced dentists who want to show what the posterior position of the mandible is, your centric relation. Well, if you push too hard, that is not going to be a comfortable position of the condyle in the fossa. so you've overdone it. No, a proper centric relation is the most comfortable position of the condyle in the fossa. That is why one of the definitions or descriptions of function of centric relation is the rest position, where the condyle rests nicely in the fossa, but not necessarily the most posterior position. The most that is not the definition of centric relation, the most posterior position. It is the position that is most comfortable according to that patient with that condyle and that glenoid fossa, where it fits nicely, but there's always a difference between the CO and the CR. If that difference is very small, most of the patients can accommodate that naturally, but some patients cannot accommodate a small deviation, at which point it begins to create damage, excess forces, which create damage, which create chronic inflammation, which creates symptoms. Now, what do you do about this? This is really the issue. And the issue is you can get, and this is fact, if you put a patient with TMD symptoms into one of these, allowing the mandible to drop back according to a protocol, because you have to have a device that allows the mandible to drop back over time comfortably. This is not a device, any old device that allows the mandible to go back, because you have to be able to leave it in long enough to allow the inflammation to die down. So there's a protocol. That's why the protocol is 24/7 for 2 months, to give enough time for the inflammation to die down, 24/7 except when you eat. But the point is, when you do this, 100% of the time, the patient's going to drop back to centric relation. What? The most comfortable position of the condyle in the fossa, which will allow the inflammation to begin to decrease because you've taken the loads off the joint. Now, when you do that, what shows up sometimes, if there is a large significant difference, and I'm not exaggerating, I've seen many patients with a CO-CR discrepancy where in their normal daily chewing their Cheerios, constantly they have a functional centric occlusion, but they have TMD symptoms, and when you allow the mandible to go back to centric relation, they all of a sudden show up with a significant CO-CR discrepancy, 4 millimeters, 5 millimeters, 6 millimeters, 7 millimeters. I can vividly recall one very young 16-year-old female years ago who literally learned how to hold her mandible forward into a relatively good-looking centric occlusion, but she already knew that her mandible dropped back, and so she intentionally, to look pretty, 16-year-old female, held her mandible forward into a centric occlusion, which totally tore up her joints. And when we put that young lady into this device, her mandible dropped back that far, and she had a significant class 2, an obvious functional malocclusion that necessitated orthognathic surgery and orthodontics. And this was not picked up by the orthodontist who sent the patient in to see me for her temporomandibular joint problems. So rolling back to, not all orthodontists are recognizing even large CO-CR problems, and definitely don't understand sometimes the significance of smaller CO-CR problems, which eventually can create damage within the temporomandibular joint, creating chronic inflammation, creating symptoms. So the second most common cause of damage within the temporomandibular joint causing TMD symptoms is functional malocclusion of different varieties. Now, when you get a small, I won't call them minuscule, but smaller difference, sometimes those can be corrected by occlusal equilibration. I would not be against that at all if you're dealing with a very small deviation which is creating a problem for a patient. If the patient is accommodating, you don't need to equilibrate. But if it's a small deviation between CO and CR that can be reasonably corrected with occlusal equilibration, then that's a good treatment. But I have again read and seen over the years many practitioners who believe that excessive occlusal equilibration is what's necessary. Or even more critical is that operative reconstruction of the bite using crowns and bridges extensively is the right way to go, which it is not. Once you get past the point that an occlusal equilibration is not going to give you significant relief on the excess loads on the temporomandibular joint, once it's recognized, then the proper thing to do would be to drop back to the next level of treatment, which would be orthodontics, and nothing wrong with that. And some orthodontists use that treatment appropriately and can move the teeth into positions where the functional malocclusion that they are treating is corrected and unloads the temporomandibular joint, decreases the excess forces on the joint, decreasing the chronic inflammation, decreasing the symptoms. But again, that can be overdone in that you can do or rely on too much orthodontics, which actually in the practical nature, I have seen so many times, unfortunately, traction on the mandible, either retrusive traction or protrusive traction, which actually does extensive damage within the temporomandibular joint and exacerbates or maybe actually creates, and I've seen it both ways, exacerbates the symptoms of TMD or literally creates the symptoms of TMD where otherwise they didn't have TMD symptoms. So these features need to be understood and to where the limits are. And there is no cut and dried parameters that I can give you. I wouldn't try. In fact, there aren't and won't be cut and dried parameters. You have to crank in some common sense into this as to what you can do reasonably and where you need some help or some other information or some other technology to work through observed CO-CR discrepancies that are causing TMD. So the people involved in making those determinations would be a general dentist, orthodontist, or oral and maxillofacial surgeon, depending on the patient themselves, how long they've had the problem, what their dentition is like to begin with, how old the patient is, whether or not they're in a growth part of their life or in a non-growth part of their life. And actually, most importantly, and I say this really intentionally, a understanding of facial growth and development. You don't have to be an expert. I'm not asking anybody to be an expert, but I do make a recommendation. If you want a very quick read, a very substantial bit of information, I would recommend reading Donald Enlow, Facial Growth and Development, Enlow, E-N-L-O-W, Donald Enlow. There's a first edition and a second edition, and it's a really interesting bit of technology on Dr. Enlow teaching you how the face grows and develops and the major facial growth areas. But most importantly, you could probably stop at the first one or two or three chapters in his book once you read how bone is laid down under what forces. Actually, the forces on bone, one way or another, allows the bone to be developed or laid down or increased in length, and how that applies to the face, to the jaws, and to the teeth. excellent information for any dentist. Very, very important and very critical if you have interest in treating TMD, because you're going to be dealing with younger patients that are in the growth phase, middle-aged patients who are finished with growth, but have gone through problems with growth, problems created by orthodontics, too much traction one way or another. The more information about facial growth and development that is out there, I believe strongly the better dentist you will be in treating TMD. One final word, and that is what I've discussed so far has kind of been limited to horizontal growth of the jaws, both the maxilla and mandible. Of course, the midface is drawn forward also, but there's a component to this facial growth and development about vertical growth also, and maxillary vertical hyperplasia, the growth and development of the sinuses and the midface bones, that it also comes into play, and actually, can create some quite unusual facial appearances in combination with horizontal growth. And once you learn about this, one of the features of this as a doctor, you're going to see, whether you're a general dentist, orthodontist, an oral and maxillofacial surgeon, you're going to be able to appreciate when a patient sits in your chair, whether they're there for a crown or just a general class 1 orthodontic challenge, or for their wisdom teeth. You will be able to appreciate a lot more about looking at a patient, having an understanding of why that particular patient in your office has an unusual looking face. We know what the Hollywood norms are. Okay, I won't go into that, but let's just call them the Hollywood norms. That's nice. The manly looking man and the pretty female, they have certain parameters. We all kind of know the nature of it. We can take a look at a patient and go, well, that patient has a very aesthetic face and they fit some parameters, which can be noted, and then there are many patients, actually most patients, do not fit those parameters and don't have a Hollywood face. But you can then understand why that is. And actually, in my case, I've got to the point years ago, and I don't focus on it much anymore because I'm so focused on non-surgical TMD. But I would have a patient in my practice, and I would imagine, without addressing it to the patient ever, but I could imagine what it would take for me to do the proper orthognathic problems to give them a Hollywood face, whether male or female. Which I'm going to end it on this one story, and I'm not sure I told this story before, but I'm going to end it on this point. In my early career, I had a young man who worked in a factory. He was a factory man about an hour from Nashville. Actually, he was in Tullahoma, Tennessee. He was a country boy, and he worked in a factory, and he was referred to me because he had a huge class 3 mandible. And I don't exaggerate. I mean, it was out an inch or an inch and a quarter, whatever that is. That's how far the mandible was out. He literally jutted out. And he was referred to me, obviously, because he had a functional malocclusion. He had a funny looking face, and he wanted it fixed. So he came to me. We did the workup. It wasn't a complicated thing to fix. It really was. The rest of the parameters of the face were okay. It's just the mandible, because of hyperplasia of the condyles, had grown way, way out of bounds. So took him to surgery. Surgery went extremely well. They wheeled him out of the operating room. I'm sitting in the operating room writing my orders. And one of the nurses, the door swung open. The nurse flies in the room. Dr. Urbanek, you have to go to the recovery room now, now, now. You have to go to the recovery room. I thought, oh my God, because he was wired together. We moved his mandible back, did the appropriate surgeries, and I flew down the hall. As I went down the hall, the double doors of the recovery room were wide open, and I could see this bed. I didn't know who was in it, but I saw literally like 6 people, 6 females, nurses standing around this bed, and I'm thinking they're doing CPR. What's going on? I'm gonna have to unwire them. What the heck's happening? And I hit the room. Get to the room. I elbow myself to the edge, to the foot of the bed, and he was laying nicely, comfortably in the bed, and 6 females were standing around him, just looking at him. And I said, "What the hell is going on?" And all I heard was, "He's beautiful. He's gorgeous." And I just shook my head. I smiled and I went back and I finished my orders. Okay. But that's not the end of the story. That's not even the beginning of the story. So 3 weeks later, he was all swollen, a little black and blue. He comes in. Most of the swelling had gone down, but he was wired together. That's when I usually see him. Excuse me, not 3 weeks, 1 week after surgery, but he was still swollen. I sent him back home. He was doing well. 3 weeks into it, he comes back to see me, and he says through his wired teeth, "You have to fix me. You have to fix me." And I said, "Sir," I said, "I fixed you already. We're done. It's over with." "No, no, you have to fix me." And that's all he would say. For about a minute, he was like getting red in the face and angry. He was getting angry. And he said, "You have to fix me." And finally I said, "Wait." I said, "Calm down." I said, Why do I have to fix you?" He says, "I can't stand it. I can't stand it." I said, "You can't stand being wired together?" "No, no, no. I can't stand it." And I said, "What can't you stand?" He says, the women, they won't leave me alone." That is a true statement. And I literally, I just rolled with my laughter. With that, I'll end it. That was a functional malocclusion. And that actually can happen, I guess. I know it can happen because it happened to me. Obviously, I didn't fix him. I don't know what happened to him. I hope he had a happy life. He should have have a happy life. He wasn't married when he came in to see me. I hope he found a very nice woman who appreciated his Hollywood face. With that being said, I look forward to the next time I can speak with you. That will be in a week. I will pick a related topic to non-surgical treatment of TMD. I am Tony Urbanek, and this is TMD Demystified.